Good morning, everyone. Indeed, I will tell you something about the clinical implementation of the NEMO device that Rick just explained. I will discuss a little bit about the intrapartum study, an antepartum study, and then I will dive into what is needed to make that happen. And in the end, I will conclude with the steps that we are taking towards the future for eCTG at home. And with eCTG, I mean electrophysiologic CTG. So first at the labor ward, this is a PhD project. So the first study that I will discuss is done by PhD student Febe Berben. And she is investigating how continuous eCTG monitoring compares to the conventional CTG monitoring. And the idea is that we can have a reduction in intrapartum interventions and hopefully a better outcome for mother and child. And why do we think this? Well, the idea is, and we learned it also yesterday, that you need an optimal amount of contractions, not too few, not too many. And this creates some kind of navigation, and if you can prevent hyperactivity of the uterus, you hopefully have less interventions due to fetal distress. And also, if you can prevent inadequate uterine activity because there are too few contractions, you might also reduce the amount of interventions. You might have less infections, and you also might even prevent postpartum hemorrhage excessive. Well, now you have a better contraction signal, that's at least what we expect to have. You might also improve your fetal heart rate pattern interpretation. So we come up with these outcome measures. The primary is to reduce the amount of operative deliveries, and secondary we also have a few objectives that we want to measure. And very important, we want to consider the 1.5 hours postpartum because that's now the first time that we can actually evaluate the contraction pattern after the delivery. And we want to compare that in relation to the postpartum blood loss. The study is ongoing, and at this moment we have 500 patients included, but we did do now an interruption of the study to allow NEMO Healthcare to come up with a better algorithm, so we will continue when the algorithm is available to us. In the end, we will have a lot of patients included in our study. The most of it is prospective inclusions, and from these prospective inclusions, the majority is with the new system. But we also do a prospective cohort of the old CTG monitor. And in addition, we will also have a retrospective cohort with conventional CTG. Who can enter our study? Everyone who has a term singleton pregnancy, and you're only contra-induced if there's something for the device while you cannot participate. The second study that we are conducting at this moment is obstetric high care. So this is an intrapartum setting. This is done by Nadine de Klerk, also a PhD candidate. And normally, you have, as a patient admitted to our obstetric high care, intermittent CTG monitoring, which means at least 1 time a day, up to 3 times a day of CTG. However, there can be events in the CTG that you miss because you're not measuring it in the fetal heart rate. So we will evaluate intermittent monitoring versus continuous monitoring, and for the continuous monitoring we use the eCTG, and we hope then to detect those events in the CTG. The hypothesis here is that we can have improved insight in the fetal condition because you will prevent missed fetal distress episodes if they are there, and that will hopefully help to improve neonatal outcome and less interventions. But also you now have continuous information available on the eCTG in a high-risk population, and we hope that this will give better patient satisfaction and also health care provider satisfaction and allow for timely and adequate interventions. Again, some outcome measures. The primary outcome here is a composite outcome where we want to reduce perinatal mortality and major neonatal morbidity, defined as in the blue box. And we have quite a few secondary objectives. And here patient satisfaction and healthcare professional satisfaction are quite important, because this is the first time that we will do such a long time monitoring in this population. Similar setup, a large prospective cohort and a large historical cohort. Again, the majority of the prospective cohort is with the new device. Who can participate in our study? Almost everyone admitted to the obstetric high care if you have a pregnancy between 23 and 32 weeks of gestation, and again the same contraindications. Well, as you can imagine, we are not a very big hospital. It will take us more than 2 years to have these inclusions. So there are some questions: how can you make those two simultaneous studies successful as an implementation in our hospital? So the next part of my presentation will be about this. When you enter a new device in your hospital, you always have to do a risk analysis, and this is done by the medical physics department. And they came up with some ICT-related issues, and one of that was we are doing surveillance, which is not similar to monitoring. And if you're doing surveillance, you also need a surveillance software tool. In our case, that is IntelliSpace. But the software from IntelliSpace could not directly communicate with the software from the NEMO system. So we needed to develop a new software module, and this was took us some time to get it done. And we had to hire an external company with it, and there was good collaboration between all the parties needed. Moreover, we also needed to secure the Wi-Fi connection in the hospital, because if you transfer a patient throughout the hospital from one part to the other part, you have to secure that the signal is always present. Well, the good thing was there that we didn't have to amend anything. But we did do some learnings here. So we had to involve ICT much earlier than we did, because we only found out when this risk analysis was performed, and maybe we should have done the risk analysis a little bit earlier. Also, I would suggest to allocate ICT hours when you apply for funding, because, well, it took a lot of time and they don't have hours dedicated for this kind of studies. And you have to include the compatibility of new devices as a part of your project timeline. A second thing which came apparent from the risk analysis was that we also had to include maternal blood pressure monitoring. That is a requirement by our clinicians, our obstetricians, and they want to have that integrated into the surveillance software. But the NEMO device did not have a physical data port to connect the blood pressure monitor. So we needed to develop the card that you see here. So the card, and you see here the blood pressure monitor, and here you see the NEMO device, and here you see the monitor. And they all had to be integrated. Luckily, the medical technology department helped to arrange that. And only when we had all those things in place, it was possible to get the approval from the ethical committee for the study protocol. Then another thing that you have to consider is data sharing. As mentioned, this is implementation study, and during implementation, you will also want to evaluate how things are going. And to improve data quality, you need a data transfer agreement with the manufacturer. And then you can allow the access to anonymous data. And what we did as a second thing to improve the collaboration was to have Ivar, our technical PhD student, to have a guest status at NEMO Healthcare. So he's hospital employed, but he also can work at the manufacturer to work on the raw eCTG data. So the raw eCTG data will stay at NEMO Healthcare, and it allows him to bridge clinical insights that he can bring from the hospital towards NEMO Healthcare without compromising the anonymization of the data. So these are things that I would definitely recommend to do. Then we had to think of the clinical personnel and how to train them to use the equipment. So there's an e-learning developed by the manufacturer. We gave that as a mandatory training. And then we had the 2 clinical PhD students on the ward in the first 2 months to help with on-the-job training. And those 2, so these are Nadine and Febo, who I mentioned earlier, they also gave regular presentations at the meetings that were ongoing to explain the purpose and the method of the clinical studies, to help with interpretation of the inclusion criteria and how to do the counseling, and of course how to do the data handling. We also reorganized clinical care a little bit, because now we have continuous monitoring at the obstetric high care. That is demanding. So we thought we need the physician assistant. We already had 1 FTE of physician assistant at the labor ward, at the obstetric high care, and we wanted to expand that. So these are midwives trained as physician assistants, and they also get, in addition to that, an in-house training of 3 to 5 months full-time, and then they become an independent physician assistant, or you can think of them as a ward doctor. And they help out with the clinical study, and they are like the central point for both the patients and the clinicians. Well, I hope you learned from my presentation that you need lots of people, lots of meetings to make it happen, and this is a little bit a schedule of how this works. And what I didn't mention, but what is very important, of course, we also included the patient perspective. And we did it with the patient panel, but also with the patient organization, which is Care for Neo. In the end, it took us more than 1.5 years more than we anticipated to allow the first inclusion. But of course, when you have that, you should celebrate it. And then in my final 2 slides, I want to give you a small preview into the future, what we are thinking of. So maybe you noticed that there's one part of patients that we didn't mention yet, so the ones above 32 weeks, before 37 weeks. And we want to consider them for home monitoring, at least part of them. Why home monitoring? Because in that setting, you will have a safe home environment, and the family life can still continue, and hopefully that will contribute to better family well-being. This is the HASTA study, and we will perform it as a feasibility study, so therefore we define it as a home at hospital study. And with that I mean that we dedicate a part of the hospital as home. Of course it is not, but we disconnect all the equipment from the hospital and enter the NEMO remote system there, and we define that as a home setting. Of course we involved ICT early from the learnings before. And we will, in this study, test the workflow for the patients and the healthcare professional, and in addition we will develop a digital twin for clinical decision support, because now you get more data and you don't want to have someone to have to look at the data all the time, but have some support there. The primary outcome here is the successful percentage of the eCTG measurements in this home at hospital setting. And of course we will look at maternal and perinatal outcomes, but because it's only with 60 patients, we don't expect large differences. We will look into cost effectiveness and patient satisfaction. And here you also see some of our inclusion and exclusion criteria, and this is just the first start. And of course, when we are getting started, which will be later this year, we will see if for all of these patient groups it is feasible and interesting to have them in a home setting. Thank you for your attention.